Hello, everybody. I am Dr. Kirschenbaum. I am the editor-in-chief of the Journal of Orthopedic Experience and Innovation. Tonight, we have a very special night, superb faculty, a very advanced and high-end early technology discussion. We are going to talk about PJI 2.0 and intra-articular antibiotics. What I'd first like to do is have the faculty introduce themselves, and we'll start with Matthew Abdel.
Great. Thank you very much. Really look forward to being here. My name is Matt Abdel. I'm an orthopedic surgeon at the Mayo Clinic in Rochester, where I serve as the chief of surgery, and really looking forward to the evening with everybody tonight. Thank you.
All right, George Gill.
Yeah, good evening, Ira. Thanks for having me. George Gild here in Atlanta, Georgia, with Total Joint Specialist. I too am an orthopedic surgeon specializing in hip and knee replacement. Thanks for having me on.
Excellent. And of course, we have Michael Meneghini. Mike.
Yeah, hey, Ira. Hey, everybody. Thanks for being here. Michael Meneghini, a hip and knee replacement surgeon in Indiana, specializing in the past 20 years in pus and cases nobody else wants to do. So, topic near and dear to my heart. So, thrilled to be here. Thank you.
It's great to have all of you. Mike, I'm really glad you take every case because we'll just get a lot of airfare out from New York out to Indiana.
There's a lot of flights coming. Well, not right now with the blizzard, but there's a lot of
Yeah.
flights. We will
Well,
take them.
all right, so let's start. We're going to start with trying to understand the problem. And Matt, I'm going to pass it over to you. You'll share your screen and we'll get the ball rolling. I think everybody has to know that if you have a question, put it into the chat and we'll make sure you get to ask that question. So take it away, Matt.
Thanks, Ira. Looking forward to being with this group. I'll spend just a few minutes talking about why I think periprosthetic joint infection of the hip and knee is the last unsolved problem we have to tackle in hip and knee arthroplasty. By means of disclosure, I have multiple individual product development agreements, which are noted here. Periprosthetic joint infection to this group is very clear, a dramatic and disconcerting problem to both patients and surgeons alike. Most series indicate that the contemporary prevalence is 1 to 2%. However, periprosthetic joint infection after aseptic revision hip arthroplasty is substantially higher, anywhere from 2 to 7%, and similarly, after revision knee arthroplasty can be upwards of 7%. We looked at our series at Mayo Clinic and published it in 2022, looking at the cumulative probability of any infection after aseptic revision total hip arthroplasty, and found that to be approaching 4% at 5 years, but substantially higher when looking at aseptic revision total knee arthroplasty, with it being 8% at 5 years. Think about that for a second. 1 in 10 patients in which we do an aseptic revision total knee arthroplasty on will have a periprosthetic joint infection with well-fixed, typically cemented implants and metaphyseal fixation. How big is the scope of the problem? If you look at the AJRR 2024 report, the scope of the problem in hip and knee in both chronic and acute situations is number 1 for failure. It's number 1 for the hip failure in the chronic and within the first 90 days. And it's the number 1 reason that knee arthroplasty fails in the chronic time period and also in the first 90 days, as you can see here. Overwhelming contributions to the failure modes in primary and revision hip and knee arthroplasty. Now, what are the contributing factors? There are multiple contributing factors to periprosthetic joint infection. It could be host and optimization. It could be the operative environment. This right here is OR84. Dr. Meneghini will know it well. It's an operating room I used to operate in. Pam and I both trained in this operating room. Antibiotics and irrigants. What role do they have? And frankly, we have to talk about the surgeon himself, herself, and the surgical technique and their teams. And there's multiple questions that surround both the diagnosis and management of periprosthetic joint infection. How do I diagnose it? IND, 1 stage, 2 stage. How do I do a spacer? If I use antibiotics, what do I use? How do I use it? When do I use it? And if I'm going to do it in a 2 stage, when do I reimplant it? And what do I do in the interim and after I reimplant it? In my mind, in 2026, when addressing chronic periprosthetic joint infection, there are 2 options: a 2-stage exchange arthroplasty or a 1-stage exchange arthroplasty. One option in my mind that's not viable is a 1.5 stage exchange, which is a 0.5 stage exchange or destination spacer, as people like to talk about it. But really, it's a half a stage exchange where you're placing a spacer in there and not complete the procedure. And it fails on both goals of revision surgery. That's long-term fixation and long-term infection mitigation. So the 5 reasons I'm opposed to a 0.5 stage exchange or a quote destination spacer is that data supports for midterm fixation, poor infection control, poor function, high complication rates, and the acceptable worst of both worlds, poor fixation and lack of infection management. Why do I prefer two-stage exchange? Right now, in 2026, you'll hear from the other panelists, but for me, I can use it in all infected total hips, such as the smatterings here that were all referred to me with periprosthetic joint infection. In my mind, current literature supports better success when including all patients, all wounds, and all organisms. And that includes staging by McPherson, looking at infection type, post-grade, and lower extremity grade. And finally, for me, it allows delay before definitive prostheses are implanted. It's much easier for me to change out the spacer on the left than to take out a highly coarse acetabular component and a fluted tapered stem. I also prefer typically an articulating spacer to provide function, provide local antibiotics, and facilitate ease of reimplantation. And the indications for articulating spacers are quite broad. Typically for me, it's no history of recurrent instability. They have to have adequate bone. You can have bone loss. That's okay. In fact, sometimes I use spacers for those with substantial bone loss to hold them out at length. And this is an example of a patient like that who's going to lose the whole proximal femur. I can't keep that patient short, and I'll do the use of articulating spacer. Now, I would spend a minute. What about the knee? There's differences between the hip and the knee, and then I'll turn it over to the other panelists. Traditionally, we've limited our use of articulating spacers around the knee, but I would say we've liberalized that, and I use a lot, in fact, primarily articulating spacers, including the distal femoral resection I'm doing tomorrow morning, and then going to put a spacer in. But I treat them like a non-articulating spacer. Traditional contraindications or indications for an articulating spacer include an intact extensor mechanism, reasonable soft tissue envelope, and adequate bone. Traditionally, we didn't do it in those who had a disrupted extensor mechanism. I'm doing it tomorrow morning in that patient. Poor soft tissue envelope, such as this patient with 2 flaps and drainage, and massive bone loss. Although I contend to you, we can build that up in contemporary practice. And why? Our infection eradication rates are okay. You have a better hip range of motion and knee range of motion after reimplantation and lower complication rates with articulating spacers. So have we really expanded our indications for spacers? Not really. We're using articulating implants and surgical techniques, but immobilizing the limb as if it's not articulating, such as this patient right here with a prior spacer and extensor mechanism disruption that we treated like this, and includes some patients with compromised soft tissues, such as this patient, which we immobilized, came back in and completed a reimplantation. Some patients still require non-articulating spacers. Here's an example, pretty rare in my mind. So even with all of that, the best data in the world are sobering on current strategies to mitigate and treat periprosthetic joint infections. And as an orthopedic community globally, we must do more. We must do better. We must change. We actually have not moved the needle, I would contend to you, in 5 decades. I present to you 2 back-to-back papers that we published in JBJS in 2019. Updated papers will be coming out later this year, both in the journal, on greater than 400 two-stage exchange arthroplasties for periprosthetic joint infection, all at Mayo Clinic, treated by us. None of them had previous infections. So the cleanest 2 stages you could possibly think about. And look at these data. The hip reinfection rate was 15% at 15 years. It's okay, but it's not great. And the knee was 17% at 15 years. And we really haven't made any progress in 5 decades. And so what I would contend is what you'll hear tonight is an opportunity for us to think differently, to actually move the needle forward, and to take an unsolved problem and provide some solutions. So thank you very much. I look forward to hearing from the rest of our panelists.
That was absolutely superb. Thank you so much. Again, if you have questions, please put them in the chat, but we'll have more than enough room at the end. Michael Meneghini, I think you're up.
Can you see my screen, Ira? Make sure it's up.
Surgical treatment. Yep.
Great. Great. Well, thanks everybody. Thanks, Matt, for a great lead into this. I'm going to expand on a couple of things related to the surgical treatment of PJI and turn it over to the rest of the group to take it home. So conflicts related here, in particular, mine are related to infection. Work with the company Oscar Remedies that's in the infection space, and then of course Scientific Advisory Board for Forecast with the team here lecturing tonight. So thanks for the opportunity to talk about it. So I'm going to focus on surgical treatment. I'm really going to focus on the big three. And it's the big three right now, and Matt alluded to this, really, is there a role for irrigation debridement and keeping the implants? Single stage exchange, which is getting a lot of attention recently, and we'll walk through where that is. And then finally, the full two-stage exchange, which is sort of like Matt, we're similar. That's our go-to for chronic infection. The considerations really for an IND are two clinical scenarios in my mind in 2026. Early postoperative infection, in some cases, an acute hematogenous infection, a well-functioning joint replacement years out, immediate onset of pain, and then really rarely, if ever, I think is an IND, a chronic infection appropriate. And I've seen too many disasters where surgeons have tried to do this. It's really a shortcut that doesn't turn out well typically. But most recently, I think this was criticized due to poor results and the risk of affecting subsequent outcome. But that data has been refuted. That was originally by Tom Foran and the Cleveland, and some of the Cleveland Clinic group. But when they showed that you can have a washout and a full two-stage still is okay if that fails, and then emerging data from Mayo shows that the IND can be good in certain situations. So we'll kind of walk through that. Here's that latest study from Matt and Dan Barry and the team at Mayo Clinic, where they looked at 90 hips with periprosthetic joint infection treated with IND and component retention. Surprisingly, there was improved results over the past decade of publications. They had only a 17% treatment failure, and that correlated with host grade. So bottom line with this summary is you can get good results if you do it in the right indications and you don't do it in really poor hosts. So a poor host is going to have less likely chance of success with IND and component retention. This is a study out of Rush and Craig Della Valle, where they looked at who succeeded with the irrigation debridement for acute hematogenous PJI. And you can see that they did all of them with the irrigation debridement and modular exchange. And the results were pretty intriguing. They had 21% failure rate, but 8 of the 9 were in staph organisms. So non-staph organisms did 96% survivorship at 2 years. So pretty reasonable results in select patients. So you can see there's like a select role for irrigation debridement. Now, when we do it, I just gave this talk to a group of fellows at Rich Berger's Fellows course. And one of the things that I emphasize is, like, if you're going to do an IND, you need to do it well. Not every IND is the same. So we sort of focus on aggressive synovectomy, remove the modular parts, really focus on both mechanical and chemical debridement. I think that's really important. That's going to get to what I'm sure Jared and team are going to talk to you about later on. You've got to hit the implants hard, and you got to hit the joint hard. And that's what those three really basic principles are all about in surgical treatment of PJI. And then you got to, of course, treat the wound carefully and do well at wound management, be meticulous around it. So Matt highlighted the 2 papers from Mayo. I often quote them in the study, but I didn't want to duplicate his work in this talk. I'll go right into our 2 studies that sort of mirror the Mayo Clinic data. This is the one where we first started realizing that consistency in protocol matters. So this was our first really look back over a decade of two-stage treatment for chronic PJI of the hip. We had 55 two-stage resection and reimplantations over a 6-year period. And we based the diagnosis on 2014 MSIS criteria. And then we were very prescriptive about our protocol. We almost never deviate. In fact, I still don't deviate very much from this. Every time we take the implants out, we get 5 sets of cultures, even if they've had cultures elsewhere. We do an aggressive synovectomy and debridement, all dead bone, all cement, get it all out. We'll reconstruct later. We do 9 liters of pulse vac lavage, dilute betadine. We've now incorporated some other solutions. And then we use an articulating antibiotic impregnated cement in almost all cases. I never typically use cobalt chrome, and we can talk about that in the discussion. And then we deliver high dose antibiotics. So the spacers that I use are typically low dose, but we affix them to the bone with high dose antibiotic. You can see the mix there for simplex P cement, different if we use a different, other cement like Palicos. We then give everyone 6 weeks of IV antibiotics. That's routine. If they happen to have something like a fungal infection or something else, then we'll go longer based on our infectious disease colleagues. But in general, 6 weeks of IV antibiotics. And if we don't get growth, which we do in a certain percentage, about 20%, we'll treat them with 2 broad spectrum. So we'll treat them with vanc and cefepime, broad spectrum to cover everything. We actually have equivalent results in our PJI with no growth, surprisingly, different than most studies, but we hit them hard with antibiotics. We then at 4 weeks get mid-treatment ESR and CRP to get a baseline for where they are. So you want to look at trends. So we get preoperative ESR and CRP. We get it at 4 weeks mid-treatment. And then that's just to get a baseline, finish out the IV antibiotics. And then we'll do a 2-week antibiotic holiday, assess them clinically. If they're looking good and doing well, then we'll recheck their ESR and CRP. If those are stone cold normal, we'll reimplant. If they're declining, we'll reimplant. If they're elevated, marginal, we will aspirate. If it's a hip, we'll do it intraoperatively. It's a knee, we'll do it in the office and get a cell count and make a determination then. We've used this criteria for years. The data out of Mayo recently and out of our shop, a subsequent study, it's these numbers, broad strokes. They all have slightly different variations, but in general, I'm an orthopedic surgeon. I like to think in broad numbers that are round and whole. So 3,000 total nucleated cells and PMN greater than 90. If I get that, I will do another spacer. And I know people gasp at that, but I will do another spacer. I don't hesitate to do that if I think there's still persistent infection. And I think some of our new technologies will help minimize that risk of persistent PJI. We'll talk about it later, I'm sure. And then in this original study, we didn't use extended oral antibiotic prophylaxis, which was interesting. And we graded the outcomes based on Delphi criteria. And we had a 96% without recurrence at 57 months. So really pretty good. Now, over time, that's going to deteriorate, of course. But we looked at that series. We looked at 57 months and had really good outcomes. So we have to prove to ourselves that we should change doing something for chronic PJI and the hip. In the knee, not quite as good a results early on, but improving with time. I think that has to do with our articulating spacers, and our technique is improving. And so that you can see pretty consistent along there, greater than 90% success since 2015. Now, let me speak a little bit about some of the modern contemporary advances, and that'll lead into our discussion later on about some of the things that are on the horizon, which are exciting. I think one of the first things that we have not really dealt with in 2-stage in the data is that we are optimizing our hosts much better. So we're using TXA. The surgical insults aren't quite as big. Our anesthesia is better. So the days when, oh my God, you went a 2-stage and you're going to kill the patient, that is not the case anymore. And when people refer to that, it's really, in my opinion, it's antiquated practices. That's not modern. So we have modern spacers. They're articulating, like Matt mentioned. We preserve bone loss. We also are much more efficient in our surgical delivery. And then we do reimplantation. We have much better diagnostic criteria for when they're appropriate for reimplantation. And now we use extended oral antibiotic prophylaxis. So here's an example of one I just treated recently. I'll just show you the articulating kind of spacers we use now that have, I think, changed the game, that people can go with these for a period of time. This is a patient who was a Vietnam vet who got hit. He was a fighter pilot in helicopters and got hit with shrapnel in a crash when they were under attack. Came into my office about 3 months ago with a draining sinus and chronic osteomyelitis that no one would touch. And so this was a native resection spacer that we were planning. Of course, I do this in 2 stages. And I'll show you this video real quick if I can get to play. Hopefully I will. See if I click forward. There we go. So what we use modular spacers now. So we can treat these much more efficiently, almost like a primary, where you can size them, trial them. And so it makes the surgical procedure efficient so you can focus on the things that I outlined before, which is debridement, synovectomy, getting all the dead bone and tissue out. You can see that cavitary defect in the tibia there for that gentleman because he had chronic osteomyelitis. We have intramedullary dowels that we can use, and this is that high-dose antibiotic with a little bit of methylene blue in there. And so we put dowels up and down to deliver that high-dose antibiotic. Now, this is an advanced technique, and I think we're getting better, but we're still not perfect, as Matt alluded to. There's room for improvement. I think one of the things that we do now, we're putting this antibiotic in the joint, but it elutes very quickly. It's gone in 72 hours, most of it in the high dose. So we're left with a low dose spacer. And yes, that's okay for preventing biofilm, but the ability to kill the organisms continually in the surrounding tissues is probably limited, which is why we put these patients on 6 weeks of IV antibiotics. I think there's better ways we can do this in the future. The other thing is we do these in hospitals, and I would love to get them out of the hospitals and do them in ambulatory surgery center. This guy required a gastroc flap. Just shows you, to Matt's point, we're doing articulating spacers on everybody. I had my tumor colleague come in and rotate a gastroc flap, and this is post-operative X-ray. Just saw him for his 4-week follow-up, and he's doing well. We're getting ready for reimplantation, but I'm taking my lead for when the gastroc flap is healed and I can elevate it. So finally, let me just comment on the single stage, and I'll wrap it up. Turn it over to the next speaker. This was like the original data. I'm a little bit against rapid adoption of this. I think studies should be done, and they are being done, but I think it's being rapidly adopted. This was the first U.S. study from Craig Della Valle. They handpicked the great patients, and it was only successful in 56% of patients, which is not great. And then this was the second study in the U.S. published, also equally dismal results. So I don't think the one stage has a great track record yet, but there's a lot of excitement around Tom Ferring's study. I would just say stay tuned. We got to see how it all plays out. Worldwide, there's a lot of heterogeneity around this topic. You see treatment all over the map in general. If you look at meta-analyses that are well done and controlled to the best that we can because of the treatment differences, it basically states there's no differences with a slightly higher infection rate with a single stage in total knee arthroplasty rather than hip. I'm going to leave you with some final common sense considerations, and then I'll wrap it up. I've always contended that when you're preventing PJI, when you're doing primary joints, you minimize room traffic, you don't perform total joint replacement in a patient with an active infection. Most surgeons in the United States will cancel a primary hip or knee replacement if they have a fungal infection or a toe infection in their opposite limb, or they got a tooth abscess or whatever. So it makes no sense to me why we're putting metal and plastic back into an infected joint in the actual joint, let alone a remote site. I don't know how this even strikes common sense to me, but whatever. People are running to it a little bit. I think we know we need to optimize patients and hosts and the medical comorbidities. When they come in with infection, their immune system is down. The last thing I think you want to do is shove metal and plastic in their body when their immune system's down and their own defense mechanisms aren't optimized. And then I'll talk a little bit about the surgical procedure, because this is what I think is the most dramatic about a single stage. Tom Ferring was the only one who's really published surgical data. We scoured the literature. No one will publish their rates of surgical times, and I know why. Look at those hours, 5.2 hours and 4.3 hours, if it's done well, like Tom Ferring will do it. Now, some people take shortcuts. I recently heard people say they do it in 2.5 hours. But how good of a debridement are you really doing if you're doing a resection, debridement, doing the draping, taking out all the stuff? I doubt that's in 2 hours or 2.5 hours, but that's his time that he and Brian Springer reported. If you look at our total time for both of our stages, because we're efficient, we put them on in the efficient machine during the day. So even though it's the last case, the team is there, the A team's there. We're not putting them on at 8:00 at night. We can do them much faster. This was our total operative time was much less on both hip and knee. Again, that's total operative time, both the initial resection and the stage reimplantation, much less. I'll end on these two studies. Kidney injury and mortality in the modern era, when you hydrate these people, you optimize them. It is not what people are quoting historically. So we've made dramatic improvements. I think that's all overblown right now. And then how do patients do? They actually do really well. We compared them to our replicating a single stage, which is our revision knees, and the two stages do very well. You take a really bad problem, you make them better. So I'll leave you with that. And I know we're going to talk about other modalities, that are going to be great for us to consider. Let me get my mouse up here to stop sharing if I can find my mouse. Sorry. But I think for sure that we're going to be making improvements really soon, which I'm excited to talk about. There, my screen's done. Thank you very much for time and attention. I'll turn it over. I think George is next.
Yep, George.
Thanks, Mike. Okay, let's go. I'm going to share my screen here. Let's see here. How are we looking? You guys seeing that?
Yep. Direct
Okay,
insights.
fantastic. I'm going to move you guys to the side here a little bit. Okay, I think this dovetails perfectly into the last two talks here. We're going to talk about intra-articular infusions for periprosthetic infection, why it may be safer and better. Welcome to the future. I do have some relevant conflicts, including some stock options and forecasts. So what is old is new again. This is not a new concept. Obviously, we've got probably greater than 2 decades of Leo Whiteside data and small studies showing that intra-articular antibiotics can be successful. But it sounds kind of crazy to some people on doing this. And if you started trying to do this at your hospital, some hospitals will just let you do it, and some you might have to go to a few committee meetings before you get this thing going. We can talk about that in the discussion. This has kind of been talked about tonight, but we just understand that the morbidity and mortality of a two-stage can be significant, and I think we haven't made a lot of progress with regard to that in the last several decades, and there's got to be something better. I think most of us are looking for something better. And we know there's limitations on DARE, which boils down to biofilm. We know there's failure rates in hip and knee DARE type procedures. DARE often fails because of debridement, which was talked about, and residual biofilm on implants. And typical IV antibiotics are not going to get above the MBEC. You'll hear this term a few times tonight, I'm sure, on the minimum biofilm eradication concentration. I also think the way in which we debride implants is somewhat archaic, and I know there's some products out there, we could even talk about that later. And if you look at the failure modalities of these 3 different treatments that Mike just talked about, DARE 1-stage and 2-stage, the common denominator is often this biofilm being the biggest problem. Once again, in a planktonic state, antibiotics can work, but once the biofilm has set up, the concentration can be 100 to 1,000 times greater than it would if they were in a planktonic state. And to me, intra-articular antibiotics is one modality of getting above the MBEC. We know there's 3 bacterial reservoirs from a general standpoint: the bone, the soft tissue, and the implants. And I think thinking about each one of these methodically on debridement and treatment is very important. And then why do our spacers fail? Some of these cases were presented just tonight. And if you look at this on some of the elution characteristics of antibiotics from PMMA, they cannot be above the MBEC after a few days. And then other issues here are the systemic toxicity of IV antibiotics. And Matt, I'm quite sure you published on acute kidney injury here, 5%. I think I've referenced your paper on the next slide at 20%. I'm sure we've all had patients with acute kidney injury, either from the spacer itself or antibiotics or a combination thereof. So we really need a mechanism for improved infection eradication. We need something that is less morbid and less systemically toxic. I think we can all probably agree on some of these points. I think there's a lot of potential benefits of intra-articular antibiotics. One, you're going where the money is, right? I think that makes sense. We talked about the MBEC. There's a chance for lower systemic toxicity. It potentially avoids the morbidity of stage procedures in certain patients. If you're going to retain implants, you're going to preserve that implant fixation and bone stock and a faster recovery and reduced hospital stay. If you look at the duration of treatment for intra-articular antibiotics, it's not 6 weeks, it's 2 to 3 weeks. We can talk about Cowley's protocol from Beijing, who I had the pleasure of chatting with in Istanbul last year. Once again, is there data to support this? Actually, yes. I mean, here's just a few publications that we don't need to go over. These are all small series, not huge series. And there's some going back to maybe the 90s here with Leo Whiteside. So this is not really a new concept. We do have a consensus statement from ICM last year in Istanbul, which I put here. And yes, intra-articular infusion is safe and effective adjunct for managing PJI, favorable safety profile and efficacy across surgical strategies. So I love this. I think that this helps us when we're getting into the regulatory sphere, talking to our hospitals, nursing administrators, et cetera. Having this sort of data is helpful for us to move forward. I'm going to share a case with you. I've been doing this technique for a while and probably an uptick in the last year or two here. This was a 73-year-old patient who came to me with a right hip chronic PJI, growing C. acnes on NGS. He's a B host with an extremity grade of 2. Here are his inflammatory markers. He has a 240 millimeter monoblock Wagner stem. His index cup is still in place. Here it is. I don't want to take this stem out. He doesn't want to take this stem out. Okay. And so I exchanged his cup to do a more thorough debridement. I did place a new cup and we did intra-articular antibiotics direct in the joint. In this case, with Hickman catheters, you can see the picture below. We have several lumens to choose from. Typically, you tuck the cuffs right underneath the skin to have a good seal. And you want to dress them. Think of it like a PICC line dressing. There's a lot of parallels. Anytime you have a question on how to do this, kind of think of a PICC line and draw a parallel. You start trying to do it in your institutions, you're going to get a lot of very specific questions. How much to flush the line? How do we dress the catheters, et cetera? So, there can be some drawbacks. We kind of talk about some of the regulatory headache. You got to collaborate with pharmacy, inpatient and outpatient. You have to be able to deliver. They're not getting IV antibiotics. So you have to maintain levels. You have to coordinate with your infectious disease team. We have a product on the launch. I think speakers after me are going to talk to this a little bit more. But the wearable intra-articular infusion system, pronounced WISE, is a proprietary catheter with an infusion pump to really help with the delivery of this method. I can speak to how to manage Hickman catheters. I will tell you it is ripe for innovation and improvement, and I'm very excited about this product. We talked about the catheter a little bit. Pre-filled syringes to try and remove some of the pain points in performing this updated technique. And once again, this has excellent success rate in many studies. It really is one of the only mechanisms to get over that MBEC. I think it has a host of potential advantages like at-home care, better outcomes, reduced economic burden, and ease of use. And Mike, you said it earlier, is this an enabling tech for the ambulatory surgery center? I certainly think so. I think we're headed there. And even beyond, do you even have to infuse antibiotics? I will tell you, we have already done a case where we're not infusing antibiotics. Not to name a product, but it's citric acid with surfactant. Does it have to even be antibiotics? We don't know the answer to that. And maybe that's a bridge too far, but we're certainly headed in that direction. So with that, I will leave you. I'm going to stop sharing, and so we can head to the next speaker.
No, this is great. Before we go to the next speaker, I just want to know, Rick Smith, you had a question or you had a comment about a study. If you're still there, Rick, you want to comment on it and see what the panel has to say about it? It was a study on single stage.
Yeah, it was just a single stage study that was done using basically calcium sulfate hydroxyapatite that is on label with Ceramide G used in single stage hip revisions. Just an interesting study to look at when you guys were talking about single stage. I know it's rather still very interesting at this point in time within the United States, but it's just an interesting study. I think you might find something good to read.
Yeah, this is the study I was able to download from his link. And I just put it up here just to make sure it's in the video. So if people want to look at this and see what it's all about. Any comments on this from the panel, or what do you think? What do you think?
Well, I haven't had it just flash up there, but it's obviously from the Charité with Carson Perka, which is a really good group. They've pushed cementless implants. Traditionally, the south of Germany has popularized one-stage exchange with cemented implants and low-dose antibiotics, but also radical debridement, as Dr. Meneghini highlighted, is their key, i.e., in a primary knee that's infected, they'll go to a hinge or distal femur replacement. And so it's an aggressive radical debridement. And what we've seen is migration away from radical debridements and migration, as you can see in that paper, away from cemented implants with antibiotics to cementless ones. I think it's a small cohort. I remember hearing Carson present it, but certainly this data is evolving, and there are so many variables.
I'll add to that, Ira. I think the single stage is a hot topic, and I don't object to it. You'll hear me speak about this in any meeting that I'm at, and I often get asked to debate against the single stage. I'm not saying we shouldn't be studying it. What I'm against is wide adoption. So I had a case yesterday with long cemented stems in a knee, well ingrown tibial cone. And I mean, I did everything I could to get that thing out without doing a tibial tubercle osteotomy, and still broke the top of the tibia. It's a devastating day. And they were, ironically, the surgeons that this poor 58-year-old active gentleman we're talking to, it was just, we're talking about amputation. And I think the problem is not everyone's going to be Thorsten Gerke or Carsten Perka when they do their debridement. And we're going to mask this thing out, and surgeons are going to see it as a shortcut. They're not going to take 5.2 hours like Tom Faring does when the B team rolls in. And Tom's retired now. If he had our post-pandemic B team in the OR that doesn't even know what side of the implants to put cement on, holy hell. I mean, I'm just that's just medicine in 2026. So anybody thinks they can do it great right now, they're lying to themselves. And I just, as long as they do it and don't send it to me when it fusses out with revision implants, I'm fine with it. But I don't see that happening.
We were a center for that one stage, two stage study as well. And I must say, when we had a few failures, it was on the hip side on a single stage, and we were doing cementless. And they'd come back at a year with a modular tapered infected stem. And the difference in morbidity and mortality in dealing with that and a
Yeah,
primary
that's right.
stem is like 1,000 light years.
Yep.
And my suspicion was that we weren't delivering any local antibiotics in that case. In other words, you took something
Yeah,
out, you put
that's
metal
right.
right back in, and it just
That's
got
right.
recolonized, right?
That's right.
And so I've become less of a fan for that. Even if it's one or two, that's a lot to me.
Yeah, George, and I think you can revisit it with technology like you're highlighting, which is intra-articular infusion. You know, Leo had some success with that in a different era, but I think you start bringing modern techniques and this sort of technology, and it can augment the treatment strategies that we have now. So I just don't know that it should replace, but I think it can take our outcomes and all the different treatment modalities and take them from here up to here. And it
Well
could be
said.
and better for the patients.
If I could say, Jared Foran from Denver. I, I've adopted one stage exchanges in the last probably 3 or 4 years after doing this one and a half stage, when I realized I was actually doing a one stage, but just putting in a crappy implant. But they were all generally all doing well, like nearly all of them. The key here, I think everybody said it, is the debridement. And if you're not willing to do the tremendously good debridement and use 2 tables or 2 rooms in doing this, you have no business doing a one stage. So that's, I think, the limitation here. And I think doing a one stage with a local antibiotic delivery will make it even that much more appealing. But we're not there yet. I agree with you.
Jared, you're right. Our ability to actually not just debride the soft tissues, but the implant itself. Like I'm going to scrub it with a Bovie pad or a lap, or I might open a scrub brush from the sink. I mean, I will also say if you were looking to innovate in the infection world and you had the ability to do a better, more thorough debridement of implants themselves, and maybe we're headed towards an era where we might be retaining a few more, I think you would be well served.
Yeah, I use a sterile toothbrush.
Sterile toothbrush. That's an old George Searney, if you ever knew him.
Yeah, I have a conflict related with it, but Osteoarthritis does have a mechanical brush you put on a drill, and you'll see a lot of things flying off that implant. You know it's not clean because you'll see it in the air. So I mean, just tell you. But this video at one time, and you'd be like, "Holy cow, what in the world's on there?" It's probably biofilm and everything else that's on there. But yes, good mechanical debridement it's important. I agree.
So I'd like to switch gears a little bit and give the floor to Dr. Jared Foran, who's going to talk about some new advance, new technology, and I know there's some other questions, but we'll do that. Yep.
Yeah. So before I do that, I want to just mention that most people know this. The great Dr. Aaron Rosenberg passed away a couple days ago, and he had his funeral today. And he was one of the greatest men I have ever known. Not necessarily even the greatest orthopedic surgeon, although he was wonderful as a human being. He was great, and just want to recognize him today. That's all.
Thank you for that.
He had a profound impact in me. So this is. I was a resident 2003 to 2009, and we were doing, what we're doing now. We were doing what we did 10, 15 years before that. We were putting antibiotic spacers in, a lot of static ones back then, putting antibiotics, a blob of polymethyl methacrylate cement. And I was thinking, this is not the way that we would choose to do this if we thought about it ahead of time. We wouldn't come to the conclusion of let's put antibiotics in this powder, in this cement, and let it elute for a few days. Back then, by the way, is when these elution curves were coming out in the early 2000s. And this is a weird way to do this. And it's morbid and it doesn't work very well. So I was thinking for a long time of a better way to treat this. And I was thinking not in terms of financial gain of a better way, just a better way for patients, truly and honestly. What is a better delivery method? And around 2017, I came up with this idea to create a antibiotic, basically a polyethylene that was hollow, that you could place liquid antibiotics in that you could elute into the joint either mechanically or passively. And I told some people about the idea and like, that's a great idea. Let's do it. Got some seed money. And we started doing that. And we had some good proof of concept stuff. But the problem is that the commercialization of that was going to be a disaster. Imagine having 1 trillion polyethylenes, every size, every brand, every, CRPS. It was just not gonna work. So with the help of a lot of the board members and Carl Demigian and a lot of people, and we kind of thought of this idea of there's already a way that this is working. Leo Whitesides has been doing this for decades and telling us about it, who, by the way, Leo Whiteside also has been telling us to do cementless knees for decades. No one wanted to listen. They're listening now. He's a smart guy, a little bit of an iconoclast, but knows what he's saying. And if you believe his literature, it works really well. So we came up with the idea of, look, the wheel's already been invented. We don't need to reinvent the wheel. It's direct into catheter-based intra-articular infusion. The problem with it is what George alluded to is it's off-label. The hospitals don't want to do it. The infectious disease people don't want to help you with it. It's very cumbersome for the patient, for the surgeon. So very challenging, right, to do that initial method. So I'm going to share my screen here. And George showed the what we came up with was basically make Dr. Whiteside's method FDA approved, make it simple for the surgeon, make it simple for the patient, take the pain points out, and it works. And it's not just his studies that have shown it works. A lot of studies have shown it works outside of Leo. I want to share with you basically where we are with the company. Forecast Orthopedics is the name of the company, and we were founded in 2017. And I kind of told you how it got started. Is everybody seeing my share screen?
Yeah, it says Forecast Orthopedics at a glance.
Yeah, at a glance, yeah. So to date, I've been very, very, grateful to have a wonderful team around us and other orthopedic surgeons that have seen the potential value of this. We've raised $8.5 million to date for this, including about 1.7 in non-dilutive grant funding. We did a preclinical efficacy study that really made me excited about. I'll show you a slide in the really showing 100% eradication of biofilm bacteria. I'll show you. We have a very experienced team, 150 plus years of clinical research work and business team. Really importantly, we've been granted by the FDA qualified infectious disease product designation, as well as orphan drug designation. And I'll tell you a bit more about those in a second. Our plan is to do what's called a 505B regulatory pathway, which people are typically familiar with the 510K pathway for medical devices. This is the drug equivalent of that, where you take an already existing drug and get a new indication for it. So it's much easier than a de novo drug pathway, because we essentially are a drug delivery company now. So it's going down the CDER or drug side of the FDA. But the QIDP, this qualified infectious disease product status, and the orphan drugs status gives us 12 years of exclusivity with our product. Meaning no other company can use vancomycin directly into the joint for 12 years. So this is essentially a patent protection on our product. We're also currently working on tobramycin for the gram negatives. We already have QIDP status for that, and we're working on orphan drug status. So our achievements to date, we raised money early on, a few $1 million, did a successful sheep study. We took Staph aureus, this is MSSA Staph aureus, basically created a biofilm on titanium discs, robust biofilm, put them in the stifle joint of the sheep, which is their knee joint essentially. And we either gave them cefazolin, since it was MSSA, or we gave them cefazolin plus intra-articular injection. This is a real slide. I'm going to blow this thing up. This wasn't crazy. We did not expect this. We expected it to work pretty well, but this basically proved what Whitesides and everybody else is saying. We sonicated those discs after we did this. The ones on the right were the ones given IV antibiotics. The ones on the left were giving IV antibiotics plus local delivery. It was all or none. It was binary. It was 1 and 0. Either it was completely eradicated or it wasn't. So this technology actually works. Getting it to the commercializing it and getting it in the hands of orthopedic surgeons is the work we have ahead of us through the FDA, through the fundraising. This is our essentially regulatory path. We are right now in the getting ready to launch a phase 1 study, and currently we are having a safety study in sheep. We've had a little bit delays with the sheep study, but it's in process right now as we speak. Then we're going to go to a phase 1 study nationally. It's really a tolerability study. We'll get some efficacy data. It's only 16 patients. Moving on to a phase 2, phase 3, the pivotal study. Hopefully, no more than 168 patients to show superiority. Hopefully less if the FDA will allow us. And the idea is to get this approved, go to market, and really change the world of how we treat joint infections. And I really do believe we can shift in addition to people understanding a better way to do a better debridement. It's not a 5-minute procedure. A really, really good debridement, mechanical, chemical, all that. But in addition to that, adding intra-articular antibiotics to destroy remaining biofilm will shift us to day-air procedures and 1-stage procedures with better efficacy than we now have with 2-stage procedures. And so that's the goal, that's the belief, and I'll turn it over from there.
Well, that's great. I feel that this is really pushing the envelope, and in a lot of ways, I call it sometimes retrovisionary. It's looking back in the past, seeing what has been done that's been smart, and redesigning it in a new way. Some questions from the audience. There's been quite a few. Dan Schlatter, would you like to unmute your mic and ask a few questions?
Yeah, I'm here, and thank you for the panel for a great evening discussion. Um, uh, so I've been doing infections, of course, in Georgia for years. As a trauma guy, I would get all the worst case scenarios that wouldn't make it to George or to Zerny when he was here. In my opinion, I think the debridements are not thorough because we're not seeing where all the bacteria is, and biofilm for that matter. And I think the next stage, in my opinion, is that we develop a biofilm disclosing agent that can be used in the body. I mean, ruthenium red is a disclosing agent that can be used in the lab, but it's not approved for in-human use. So something that's non-toxic needs to be developed, and I've been working on that for years. And I even have IP on it now.
It's a great idea.
Thank you.
That's good.
A poor man's version of that is methylene blue, but
It
not a very good solution.
overstains everything. Sorry, it's too sensitive, and that's been reported in about 4 different studies that it just stains everything. I mean, it can be used as a marker to tell you if you've done your debridement, you've hit everywhere. I agree with that, but I mean, the other thing that's scary is that there's been reports recently that Staph aureus is in osteocytes and in skin cells, keratinocytes. I mean, how do we know where, we've done our debridement? Because it's not unlike in tumor where you can figure out where the margins are, tumor margins, we don't have bacterial margin markers yet. In intracellular and intramedullary, I've seen that a lot in treating infected total knees. When you take off, the implants, there's just pus dripping out of the canal. So, I mean, that's another source. There's 2 sources that we don't see. And I think that's a big part of the problem. And I think phage therapy is going to, address that and solve that. I mean, that has very good data on getting intracellular.
Dan, your comments are salient, and I think, we keep talking about debridement. Let's say you're going to do a DARE and you're a good debridement, okay, and you're looking for biofilm and where it is. I mean, raise a hands on the panel. If it's the knee and you're debriding a femur, who thinks on the backside of the knee that you can't get to between the implant and the bone that there's biofilm back there or bacteria back there. I mean, I kind of do. I don't think like magically the bacteria don't go to the other side of the implants that we can't get to. And you can't debride there. And that's why we resect these things from time to time. So we don't have a good way to clean implants on the parts we can't see.
I agree entirely. There's data coming out on that. I just finished a retrieval study out of SUNY Buffalo with my mentors up there, including Brian McGrath. Of course, you know him. And when the explants were taken out, I looked at them in a back table with biofilm, and I now have data showing basically mapping where bacteria is. And you're exactly right, George. It's all over on the back of the implant, and you can't get to it. You can't see it. And because you can't see it, you're not going to go after it, and there's no way of getting to
And
it.
I would say that's exactly the hope and the reason to get to MBAC for a sustained period of time, to get to those that we can't get to otherwise, as of 2026.
As always, this is always the fastest hour in orthopedics. I'd like us to sort of sum up a little bit and maybe respond a little bit to William Watson, Williams,
Will I am.
Will I am. But more importantly, this is such an active uh, area because the problem's so remarkable, as Dr. Abdel pointed out and George pointed out. So I just want to go around the panel and get your thoughts about the next couple of years and where this technology, your technology, other technologies, where are we going to be and what kind of results are we looking to see? I'll start maybe with Jared. Jared?
Yeah, I think it's an exciting time. There's a lot of people putting a lot of thought into doing this better, finally, right? I don't think one thing is going to be the answer, but I think when you combine all these different technologies, we're going to get it.
Yep. George, you want to give us
Yeah,
a
I
comment?
guess this is an aggressive question is who would you not do intra-articular antibiotics on for PJI? In other words, you don't treat them for as long, it's less systemically toxic. The data is looking good. We need more data. But at current, they're all getting PICC lines in 6 weeks of IV. And really, most of the roadblocks are regulatory and not medical. So I think it shows great promise. The only person you wouldn't do it on is someone who came in with frank sepsis and an infected joint. Now, those people still need IV, right? That might be someone you wouldn't do it on. But short of that, I mean, you know, I guess there's theoretical concerns on getting a fungal infection on the line, right? I think Leo had some reports of that, or developing a sinus tract, but we never saw those sinus tracts form. So I think you have to be careful, but I'm excited and we're going to keep doing this. And we're looking forward to this product from Forecast.
Matt, some comments?
Listen, I think these things are additive. They're not replacing, you're not eliminating. So I think the intra-articular antibiotics is definitely going to be the future. I think it's archaic. What we're not doing right now is just ripping things out, saying stay in bed for 3 months and come back in. So I do think that's going to be the future, but it's going to be in combination with IV antibiotics, some other treatment modalities. And I'll let Dr. Meneghini comment, but I think we've got some very exciting data and future with some local delivery of some non-antibiotic as well. And I do think that there's some ability for that, but it's going to require data and it's going to require good data and it's going to require data in appropriate patient sets. And I think that's the key when we think about these washes and irrigants. But in particular antibiotics, that's here and it's here to stay. And that's what's going to move the needle.
Michael, you want to take us home for tonight?
Yeah, Jared mentioned it. I think the future is intra-articular delivery for sure, and it's going to replace systemic, which is the one that patients don't want to have, obviously. The other thing you can't ignore, the two things I'll finish with. Number one, Jared mentioned Leo Whiteside earlier. He's a dear friend. I took his flag up 20 years ago and carried cementless knees where it is today. I've talked about that for a long time. And the other thing he was doing was IV infusion. And he was a pioneer, and he was quite frankly a little wine before his time. But now it turns out what he was saying was right. Second thing I'll mention that no one's really talked about are the macroeconomic forces in the world. I deal with them on a daily basis through AUKUS. And the other issue is you're gonna have to have the answer for the migration out of the hospitals into the ASCs. And where is the money going to come for such a small problem but a heavy economic burden? So that's really going to be where the rubber meets the road in innovation. Matt's right. We need good data. We're also going to need money, right? And the money is a unique thing these days. Not only just money to do the studies, but money to treat the patients. So all these things are going to affect the development of this technology. But I absolutely think it's unquestionable that we're headed towards intra-articular delivery of the antibiotics to protect the host, which is the patient.
All right, so I'm going to, like I said, the fastest hour in orthopedics. Like I think someone at JIS could have gotten 7 joints done by 9:07 Eastern Time. I want to thank the panelists. This was really one of the great topic sessions, introducing a new topic in an old problem, which I think is amazing. Sincere thanks to a wonderful panel, amazing topic, amazing product. I want to say thank you to all of you and good night.